This is Healthcare Now Radio's Trending Now. Get ready for an exhilarating 30-minute ride through the latest topics driving change in digital health across the news and social media. Join us as our subject matter host takes the lead in uncovering what's hot and what's not. So buckle up and tune in to stay in the know.
Welcome to Trending Now on Healthcare Now Radio, where we explore the forefront of healthcare innovations and transformations. I'm your host, Shahid Shah. Today, we're thrilled to have Dan Marino, a managing partner at Lumina Health Partners. What's trending now, and what Dan and I will discuss, is the economics of value-based care versus fee-for-service care, and do so in a very thoughtful, practical way by specialty. Like healthcare is a multi-trillion-dollar industry, and saying value-based care is great without saying, what is it for your business versus your specialty, et cetera, is a little crazy. And that's why I'm really excited to have this conversation with Dan, because he's been doing this for a while. And so, Dan, tell us a little bit about yourself.
Well, Shahid, I'm real excited to be on your show today and talking about this. Thank you. So we've been involved in value-based care before it was actually coined value-based care. I started in the mid-2000s, and I had the opportunity to actually work with a large health system in Chicago, which wanted to engage in a payer contracting structure different than how they had traditionally done it. It was, in the traditional model of fee-for-service, you're getting paid for the number of patients you see, but quality isn't really part of the equation. So this particular health system thought that they were delivering actually really good quality. They wanted to be able to showcase that. And so we had actually helped them to aggregate a lot of their information in such a way that they were able to tell the story, the quality story. And then lo and behold, it caught the attention of a few of the payers and the leadership, and they decided, hey, maybe we can create some type of performance contract around there, or some type of performance incentive. And frankly, in my experience, that's really how value-based care took off.
Mm-hmm. Yeah. So when you think about value-based care today, and you hear some of there are lots of people that are positive about it, and they should be, because obviously that's the direction that Medicare and all government payers, all commercial payers would love to go to value-based care. But the reality is fee-for-service is still king of money grabs right today. So tell us a little bit about what is the reality of value-based care in terms of dollars at some of the most successful places that you've seen them versus the reality in some of the places where they're not succeeding and they're kind of like going back to fee-for-service.
Yeah, that's a good question. Intrinsically, everybody believes that value-based care is the right thing to do because it incorporates quality into the way that we deliver care to our patients. But the reality is, the economics, the financial incentives associated with value-based care hasn't caught up to the economic streams of providers. And there's a number of reasons for that. Some of it is the way the structures are set up, the contracts are set up, the organizations are set up. They haven't been coordinated enough to integrate the clinical aspects of care across the network. So it's hard to actually put yourself out there and have a contract if you're not confident that you can deliver clinically around the performance of that contract. So what we see is there's a pretty good scale of economic return or performance associated with value-based care. So you may have one large group who believes that they're clinically integrated, but may only have 1 to 2 to 3% of their revenue tied to value-based care. It's hard to create that momentum if you don't have the financial incentives that drives the performance. There's another large organization that I've had the opportunity to work with in Idaho. They've invested tremendous amount in their culture, in their infrastructure around creating this value-based performance. They have 30 to 40% of their revenue tied to value-based care. So again, when you look at those two organizations, the culture, the mindset, the delivery of care is definitely different, and it does follow the money, but it also follows the performance outcomes that are inherent in delivering good value-based care.
So, Dan, where would you say that many of the failures, with all good intentions, what are your top 2 or 3 or 4 failure conditions that you walk into an organization, you look at them and say, well, there's no way you're going to get value-based care working ever, right? So, sounds like the organization, the culture, the people, the technology, et cetera, all those things are wrapped into one. But tell us, what are some of the major failure conditions that you've seen?
Shahid, it comes down to people, process, and technology, right? It's really what it is. So from a people standpoint, you have to have the right governance and the right incentives and the right culture to drive to align your providers that will really drive the right level of outcomes. Physicians have been used to practicing in a fee-for-service environment for many, many years. Value-based care is a little bit different. To be able to go to a physician and to say, look, maybe you don't have to see that patient. It might be better for you just to review the record, provide some thoughts, or call the patient, some of which is really billable, right? It's not economically advantageous to the physician to do that, but it's the right thing to do, and it drives the right level of performance. That's a culture shift. The second around process, you have to have the right process in place that leads you to be clinically integrated. You have to look at the data. You have to change the way that you're actually treating and interacting with the patients. That's more performance, that's more outcomes driven. You have to have the ability to trust your physician colleagues that you all are going to be aligned around the same outcome for that patient. And again, not necessarily lead with economics, but lead with outcomes and with performance. And then third, the technology has to support it. Value-based care has to produce efficiencies within the organization, within the network. Our physicians are way too busy as it is. We can't ask them to do more. We actually have to ask them to do less, but to be smarter about the care that they deliver. So the technology has to be able to provide efficiencies that lead to the outcome, that builds the trust within the physician community. All of that is really what drives the outcomes. Many organizations find it difficult to invest in a lot of those elements and really be able to move the bar, so to speak.
So it sounds like when you talk about value-based care, because the practitioners, the providers themselves are doing most of the care, there are obviously enormous amounts of help around them, but where it's been successful, say in that Idaho example, what does the thinking of the physicians there look like versus the thinking of the executives, as opposed to like where it's not working, how do physicians think versus how executives think?
Yeah, so if you look at the organizations that have been successful in value-based care, and Advocate Health System in Chicago is one, Kaiser Permanente has been another, Geisinger has been a third that come to mind. Those organizations have been physician-led that have really changed the mindset, moving from fee-for-service to fee-for-value. Those organizations that have been very, let's say, financially driven, very fee-for-service focused, have been more administrative-led, if you think about it. So the key that becomes really important on beginning to align the physicians is having that physician leadership in place, making sure that we have the right level of incentives and we have the right level of support structure. And, we're going to ask physicians to trust in the process to deliver care differently. In some cases, that trust only goes so far. You have to be able to create the right level of incentives, and they have to see that return. And getting back to one of your earlier comments, that's one of the big challenges, because the contract and the financial return isn't necessarily there to keep that trust factor going.
Yeah, so that's fascinating. So as an engineer, I love to hear patterns, right? And so if you're saying, well, hey, if you guys are very administrative led, you don't have a lot of physicians in leadership, maybe you should rethink this idea that you're going to get to value-based care in some short period of time. Maybe it's a cultural shift and lots of changes. But if you're already physician led, you're a great candidate, right? And maybe we can pick up on that after this next couple of questions. So you've mentioned incentives a number of times, and I think there's general agreement that without the incentives, things won't work. Where the same kind of question applies is where it's working, what is common about incentives, and if you can go into a little bit of details with examples, that'd be good, versus where it's failing or not working as well. What do the incentives look like? Everybody has to have incentives,
Yes.
but some of them might not be working well.
Yeah, that's true. So when you think about the incentives, what drives our behavior? Well, the number one is financial, right? So typically we need to have some level of financial incentive that helps to drive the behavior change. But in this day and age, that's not the only incentive. So work-life balance is an important incentive. Making sure that you're creating efficiencies are incentives, and also delivering the right level of care to the patient is an incentive. So when you think about, let's talk about primary care as an example. A lot of primary care physicians are extremely overworked. They put in a lot of time. Many of them that you talk to still struggle after 10 or 15 years of their EMR, still struggle with spending too much time, too many clicks, too much in their in basket, and so on and so forth. To create that incentive around efficiency is really what will drive a lot of their alignment and their ability to make that change. When you look at organizations like a Geisinger, for instance, they have the financial incentive in place. They provide work-life balance to their providers as an incentive, and they also allow the physicians to have a certain level of autonomy in the care that they deliver around what that level of outcome and performance needs to be. And they work as a team. They're all clinically integrated, which is really key. So those three things, I think, are important drivers as you start to create the incentive model to really lead you into value-based performance.
Yeah, what that reminds me of, Dan, is that a few years ago, when I was running a conference, one of our keynote speakers was from Hawaii Pacific, and they have this program there at Hawaii Pacific called "Getting Rid of Stupid Stuff," right? And you just look at that, look how simple that statement is. And by the way, there's I don't know if it's in the New England Journal of Medicine that this article is in, but if you just look for anybody listening to this, if you're in your car, don't do this now. But if you're sitting at your desk, look this up. Hawaii Hospital, get rid of stupid stuff. That is such a beautiful article, which basically captures exactly what you're saying. Like, docs have been asked to do not inefficient stuff. They've been asked to do crazy, stupid, silly things all the time. And that may be one of these things that we work on, is to say, hey, man, if you're trying to get to value-based care and you're still doing stupid stuff, how about you stop? And hey, if you're wondering what those stupid things are, here's an article, a peer-reviewed journal article that you can take on. And I think, so as you mentioned the incentive side, I'm actually very glad to hear that the financial side doesn't have to drive all of this.
No.
That work-life balance, the idea that you're giving people something to do during the day, which is meaningful. Talk a little bit more about that, and where you've seen this successful, how much of a big part is that versus money?
It's a really big part. Certainly for some of the specialists, I think it really comes into play. A lot of the specialists struggle with how to get into value-based care. They understand that it's coming. They're reading the articles. It hasn't quite touched them. And from a financial standpoint, they're working really hard and they're making good money, depending upon what the specialty is. But as you start to move into value-based care and you're solving some of these issues around shortage of providers in their specialty, or the ability to take on additional call, or the ability to take care of patients and treat patients in the hospital versus the surgery center. Those are work-life balance issues, which really drive performance outcomes that if you can build that into your model of value-based care, that becomes really powerful. And it becomes powerful from the standpoint that you're meeting the physician where they are in their career. You're allowing physicians to make the determination and the decision about whether they want to continue to work really hard and churn and burn and see a lot of patients and make those incomes, or you want to also incorporate some work-life balance, still get rewarded well because your performance outcomes are where they need to be, and maybe even in the top tier as compared to your peers. So those level that what I really call the investment in the providers has to be part of what you want to do as you start to really build out value-based care and take that to the next level.
No, I love it. And of course, when we say providers, we absolutely mean nurses, whether it's an RN or an LPN, it's a pharmacist. We have to bundle them together because they're all the providers together. If you're just tuning in, you're listening to Healthcare Now Radio. This is Trending Now. I'm Shahid Shah, and I'm having this fantastic conversation with Dan Marino, managing partner of Lumina Health Partners. And what's trending now, and what Dan and I have been talking about for the last 10, 15 minutes is the realities and the economics of value-based care. And Dan's taught us a lot in the last few minutes about the fact that not all incentives for value-based care to providers have to be numeric and monetary and economic driven. There's a lot more life type of things that can be incented on. And he's taught us that there are people that are succeeding with value-based care, numbers almost as high as 30, 40, 50% of your entire revenue model could be built if you're successful on value-based care. Now, assume you buy what Dan is saying. Let's get some free advice from Dan to say, okay, what if I am a physician-led organization and I want to get more into value-based care? How high should I prioritize it? Like, how meaningful would it be to a maybe already either middle of the pack or higher than the middle of the pack organization? Is it really something that I should be looking at now? And if I do want to, where do I start?
Yeah, I think you have to look at your market, what's going on with your patients, and in particular your payer community. One of the areas that we didn't touch on that I think is interesting to kind of throw in here is the payers are at also different perspectives, different, let's say, paces of shifting to fee-for-service to value-based care. So if you're working with, say, a United Healthcare, which has invested quite a bit in value-based care and has some interesting value-based arrangements, if you're a medical group that has quite a large population of United Healthcare patients or members, lives, if you will, you want to have that conversation. You want to prepare your organization for moving forward. If you're in a state that has, say, a growth of 15 to 18% a year in Medicare Advantage, and most of those Medicare Advantage plans are within a reputable commercial organization, you want to have that conversation to layer on a performance-based element to the Medicare Advantage contract. So understanding where your market is really key, because then that allows you to take advantage of some of, hopefully, the performance outcomes that you have within your organization. But one thing I do want to mention, there are some core capabilities that you need to have within an organization in order to be successful within value-based care. It needs to be physician-led. You had mentioned that. You need to have the right governance model. So you need to have physicians managing physicians. Administrators should support the process. They should add the business acumen to the conversation, to the structure. Physicians need to drive the clinical performance and the outcomes. And then you need to have the right incentive structure in order to align it. If you create that and you invest in that infrastructure to support it, your ability to meet your payers where they are to drive that level of value-based performance, you have a better opportunity of success, and you'll continue to move down that path of moving into even a stronger value-based agreement over time.
And it sounds like that, and maybe this is an obvious statement, but you could do all of the stuff you're talking about and not even do any value-based contracting, and your fee-for-service environment will be better as well. And
Yes.
that helps you with transitioning to value-based care. Is that reasonable?
You're absolutely right. And that's a great observation. So one of the engagements that I'm working on right now is we are putting together a statewide dermatology-based clinically integrated network in Florida. We have 350 dermatology providers signed up, and we are in the process of having conversations to be with payers to be able to transition into value-based care. But what we're finding is we're actually solving for some of the fee-for-service issues around access, not being able to get in, issues around aligning with their primary care physicians, issues around being able to provide the right level of treatment and properly incorporate utilization management into the care of the patient. all of that is actually benefiting the fee-for-service model while we're actually positioning for value-based outcomes, value-based contracts.
Now, that sounds fantastic. And in fact, that's a great win-win for folks who are serious about value-based care is, look, forget the value-based care part. Just get all the core efficiencies, the governance, the physician-led part, the incentives, the work-life balance, get all of that started. And that might teach you a lot of whether you should even deal with contracting and going to your payers, et cetera. So that seems like a really good thing to do. But when you say study your market, that's obviously a lot easier said than done. So let's talk about maybe 3 different marketplaces. One, heavy, dense urban populations and practices in that area. The second being suburban population, still not, not rural, but certainly not as dense as the urban population. What does it look like there? And then if you look at the rural and non-suburban type of marketplaces, does it matter? Does value-based care matter in those areas when the the total number of patients and the population size is small? Does it matter what kind of organization you're sitting in that market space?
Absolutely, it does matter. And I'll tell you, the common denominator in all 3 of those markets is the cost of care. The goal has to be to not necessarily reduce the cost of care. We need to slow the growth of the cost of care. I think I saw in the latest statistics that healthcare now is projected to grow somewhere, don't quote me exactly on this number, but I think it's about 14% or so for this next year. So healthcare is back growing much higher than the inflation rate. We as an industry, it's not sustainable, right? We've talked about that time and time again. So the common denominator is to reduce the cost of care. So whether you're in an urban area, you're in a rural area, you're in the suburban area, as you start to think about clinically integrating, as you start to think about creating an efficiency in the care that you're delivering, whether it's in a fee-for-service or it's in a value-based care arrangement, efficiency will drive your opportunity to reduce cost and to better manage costs. And, and frankly, it's the right thing to do with the patients. If you're bringing patients back every 3 months, and they don't necessarily need to be brought back every 3 months due to the clinical protocol, or there's different ways to be able to provide that visit, maybe incorporating a virtual health visit, which is certainly less expensive. That not only benefits the patient, but it benefits the industry. And where I say that, when I have conversations with leadership around that, if you can show that you have good outcomes around delivering efficient care at the same time where you're showing you're decreasing your cost of care, there's a value in that. So that's where the economics come in. Share that value. Share that value with the payer, with the payer. Share that value with the employer. And they're willing to do it because, again, they're investing in the healthcare of their community. So, and getting back to what your initial question, I believe all 3 of those around that common denominator are very similar. The approach may be different, but the outcome is very similar.
Yeah, and the reason why I brought it up, Dan, is that a lot of people believe, well, our community is too small, we can't really do value-based care. That's not true, right? Or we're suburban, we're not competing against academic medical centers, and we're like, everybody's competing with everybody in the virtual world. So it seems like it should matter to everybody, but it doesn't quite. So in the spirit of staying with this idea of what baby steps people could start to take on their road to value-based care, I know you guys help at Lumina Health Partners with managed care contracting and clinical service line development. What could you do there to help prepare to the value-based care?
There's 3 things. One is the organization, as they're thinking about moving into value-based care, whether they're dabbling in it now or they're really engaged in it. You have to have the strategy and understand where you want to go, right? If you don't know where you want to go, any road is going to take you elsewhere. So you have to understand where you want to go and the strategy that you want to take to get there. The second thing is that you do have to have governance and the incentives and be able to create the culture alignment. We had talked about that. And then you have to engage your payers. You have to engage them in a different conversation around collaboration, around partnering, so you can get some level of a value-based contract. And a value-based contract doesn't mean moving into a full risk contract. It could mean something as simple as a pay for performance contract, right? Submitting data And if you hit certain thresholds based on that data, you get some type of a performance incentive. Very basic, but what it does is it helps to move the culture towards a greater focus of value-based alignment. So really, again, strategy, governance, and then engaging your payers with some level of a contract.
Nice. So in the last couple of minutes that we have, let's talk a little bit, drill down a little bit further in that contracting with the payers. What are some gotchas? What are some pitfalls as we take our audience out in the next minute and a half?
Yeah, absolutely. First, I think the biggest thing is making sure that as you're engaging in a contract around value-based care, you're clear on what you're agreeing to, right? Risk scares everybody, and risk means different things to different folks. In some cases, risk means if I don't succeed, I'm going to have to write a check back to the payer, and obviously nobody wants to do that. So I think the first thing is understanding where you are on delivering value-based performance and creating a contract that, one, properly rewards you, but two, helps you to continue to move down the path of eventually moving into risk. Because if you're able to do that over time, and sometimes that's a 4 or 5 year journey, that's really what economically makes sense. I think the second thing is you have to be ready to have conversations with your payers different in a value-based contracting arrangement than you would in a fee-for-service. Very different. You want to have it around collaboration, not beat each other up sitting on the side, each side of the desk.
Yeah, this was an awesome conversation, Dan, and I hope audience members will get onto the websites, click on your links, and go look at all your other materials. You are also a fellow host on the Healthcare Now channels as well, so hopefully people will listen in on those when they want to drill down a little bit more. But here's what Dan taught us in the last 15, 20 minutes or so. Number one, everybody can do value-based care, but you're better off if you start with physician-led organizations rather than if you're administrative-led. The nicest way of saying that is if you're led by a bunch of bean counters, don't go to value-based care first.
Great point. Absolutely.
Right. Second thing is the incentives don't always have to do with dollars and cents. Make life choices matter. And the last thing is every market needs this. So that is a fantastic way of getting this started. And if you have an interest in what Dan is doing, definitely reach out. And to our listeners, thank you so much for joining us on Trending Now and on Healthcare Now Radio for this very engaging discussion. Stay tuned for more episodes where we explore the latest trends and innovations shaping healthcare's future.
Thank you, Shahid. Appreciate it.
All right.